Запис Хмара, будь ласка.
Я запускаю вже запис.
Так, дякую.
І приймаю всіх.
Доброго вечора, шановні колеги. Good evening, ladies and gentlemen. Good evening, my dear colleagues. And today at last we are doing the third webinar dedicated to the acute aortic syndrome, which is presented, which is kindly brought to us from our colleagues from Canadian Emergency Trauma and Acute Care Radiology Society. And we're very happy today to have Professor Fergus Berger with us. And please, I would like to welcome our head of a society, Tana Linska, for the invitation and a welcoming word. Thank you.
Thank you very much, dear colleagues. Today, our lecturer, our colleagues from Canada, Professor Fergus Berger. And Fergus Berger is a Dutch radiologist specialized in emergency and trauma imaging. He focused on his topic in the later half of his radiology residency training at the AMC in Amsterdam. Further specialized in the field through the fellowship in Vancouver, where he had a subsequent fellowship in musculoskeletal radiology imaging. And Dr. Berger is dedicated to trauma and emergency imaging in his teaching, research, and clinical work, and is associate professor in the University of Toronto, associate scientist in the Sunnybrook Research Institute, and deputy chief of the Department of Medical Imaging and the Precision Diagnostics and Therapeutics program in Sunnybrook. Outside his institution, he has also been enthusiastically contributing to the societies representing the field, the emergency radiology. He served on the board of the European Society of Emergency Radiology. Since its founding in 2011, served on the executive committee of the American Society of Emergency Radiology since 2018. And on the founding board of the Canadian Emergency Trauma and Acute Care Radiology Society since 2020. And we are happy today to listen to your lecture, your presentation. Please.
Thank you very much for the very kind introduction and the opportunity for me to speak on acute aortic syndrome today. I have nothing to disclose pertaining to this lecture, except my very deepest sympathy for the situation in the Ukraine and my thoughts to you and everyone in the country, as well as those who have had to flee or otherwise were affected abroad. We have a large contingent of Ukrainian people already living in Canada since far before the current situation. I would also like to express my thanks for allowing me to speak on behalf of the Canadian Emergency Trauma and Acute Care Radiology Society at this third webinar in the collaborative online educational project with the Association of Radiologists in the Ukraine, which is called the Online Radiology Seminars. It's a privilege to be here with you today. The objectives of my talk are to know some deciding points of the imaging protocol in selection and optimization, understand the classification systems and some controversy, describe the different entities of the acute aortic syndrome and how to distinguish them. And then I will end by showing some challenging cases. So the content of my talk will first deal with the CT technique considerations. Then we will discuss the imaging aspects and clinical aspects of the acute aortic syndrome and the three different entities that you see here, the classical dissection the intramural hematoma and the penetrating atherosclerotic ulcer. And we will go over the imaging features. And then I will show some cases. Before we go into the content of the talk, I would like to present you with this radiograph that you may see in your institution. And you know the topic of this presentation. So I'll give you a second to look at this image and see what you would say of the chest radiograph. A second case I would like to show is a CT that you can see here, and you will notice that there is a dissection, so that's already given, but I would like you to think what you would make of this contrast blob within this non-enhancing part of the aorta, and I will get back to these things later in my presentation. First, let's focus on technique on how to scan the aorta and especially the thoracic aorta. I first want to start off by saying that it depends a lot on the local situation, more so than many other things in imaging. And in part that has to do with the pulsation of the heart and the aortic root and the aorta itself as well. So I would like to go over some questions that I will present on the next slide for you to think about that will influence the decisions that you will make for CT technique of the aorta. And then after that, I will show my own setup because that's important for my talk as well. So questions about your setup is to think about the scanners and especially what age are those? Are they over 10 years old, which in Sunnybrook till a year ago was the case. Most our scanners were 12 or 14 years old. Apologies. Are they 5 years old and more adequate with the time? Or are they even brand new and can they scan really fast? Together with the age is the acquisition time. So can you scan the chest within 5 seconds, within 2 seconds, or even under a second? Are you able to do ECG triggering for the chest? And if yes, can you do it round the clock every day of the year? Are you able to do dual energy CT? Because that may change the protocol of scanning as well. Is your CT in the emergency department? And are technologists on their own, or is there a radiologist available? And then the final very important question for technique is who treats the aorta and what do they prefer? Because it is a team discussion on how you do your imaging. So let me show where I work. This is the campus of Sunnybrook Hospital. This is the new component of the hospital, and there's the old component of the hospital. You can see there's a big campus that that constitute our entire hospital. To show a bit of an impression, this was the COVID field hospital that we had built, and that's just this parking lot here. It was 100-bed capacity. We recently added a helicopter pad, which means that the patients can now be transferred from the helicopter to our scanners and our operating rooms without being outside. This hospital has over 1,300 beds. Almost 700 of those beds are dedicated to acute care, and we have 128 beds that are critical care beds. There are over 12,000 employees, over 1,000 physicians, and more than 350 people work in the medical imaging department. About 45 qualified radiologists and about 20 to 30 trainees at all time. So that may look impressive. However, this is our entrance to the emergency department. So the walk-in of people who come themselves and the ambulance are right next to each other. And as you can see, this is not covered. So not everything is better in another world. Patients, when it's minus 40 or minus 30 feel factor outside, They are still being rolled outside through the snow and into the emergency department. What is very new is our setup of the emergency department CT. So this is where acute care is now being reported. You see the emergency department corridor has its opening into the CT suite, and the main corridor has an entry to the patient's holding area for patients from the ward. And both these have access to the CTs. There is an ultrasound room as well. And you can see there's the control room for the technologist, and we have now an acute care reporting room for our radiologists to do the reporting of the acute care. So this is the new CT that we have since about a year. It's a Force from Siemens. And this is the first patient getting scanned who provided consent for the image to be used. And this is where the technologists sit to scan the patient. This is the radiology reporting room. There's two colleagues, one from cardiothoracic and one from abdominal imaging, reporting the studies. And this is where I do my night shifts, the emergency and trauma radiology station with a dashboard to see what's coming, what needs reporting, what is red, which means it's been waiting too long. And our shifts at night, we are present here from 10 p.m. till 8 a.m. and we also work during the day. So this is the setup which I wanted to share because it is where a lot of the images from the presentation are from. So let's talk about technique and the phases to obtain. If you have it available, acute imaging of the aorta is always multi-slice detector CT. The phases we obtain are a non-contrast of the chest, and that is to detect the hyperdense intramural hematoma or thrombus in the false lumen, but also to detect surgical material if there was a prior surgery to the aorta. If you do have dual energy CT, you can skip this phase and do a virtual non-contrast CT from either the arterial phase or the portal venous phase. So after the unenhanced CT, we do an arterial phase CT after contrast. And this is mostly to see where the dissection flap is and also if branches are involved, as you can see here, the aortic arch branches. I was trained to always include a portal venous phase of the abdomen and pelvis, mostly to assess organ perfusion, because that's actually one of the things that patients would die from, as you can see here in the differential enhancement of the kidneys due to renal artery involvement. You do that at around 60 seconds. However, if there is prior stenting, you would probably want to do it at 90 seconds to be more accurate on picking up endovascular or endo leaks from the prior stent. One very important thing to stress as well is that if it is at all possible, contrast should not arrive through the left arm because you cannot judge the aortic arch branches. And you can see here, the contrast is not arriving from the left, but it arrived from the right. And you have a much better picture of the proximal branches from the aortic arch. So if it is possible, it isn't always possible, but if it is possible, please administer the iodine through a right arm access. And a few words on ECG triggering. Is it needed or not? Here you can see 3 images of the same patient. First, an image without ECG triggering with a lot of pulsation artifacts. And then 2 images obtained or retrospectively reconstructed from a volume triggered scan, one at the 75% of the RR interval and one at the 55% of the RR interval. And there's still some pulsation seen in the 75%. So the advantage of a volume scan is that you can actually choose which is the most important or most optimal RR interval. However, do you really need it? It is a known pitfall, and it is quite characteristic in appearance. Non-gated scans offer far less radiation exposure, which is also important, even though the patients are usually older in this set. Non-gated is therefore preferred, especially in the younger patient that has a low pretest probability. And if you get into trouble because you don't know for sure, you can always still do the gated CT if you have enough resources, of course. Local settings with maybe shortage of iodinate contrast could sway the decision to do an ECG triggered always. If you do trigger, still try to keep the heart rate below 65 beats per minute. Even if the newer scanners can scan at higher heart rates, it's always better to reduce the heart rate. Again, if you do have one of those newest scanners, choose for a protocol with high table speed and you will hardly ever need a triggered scan. Let me show you this in this example. On the left, you will see a routine scan that takes about 5 seconds. On the right, you will see a high table speed coverage with about 70 centimeter seconds, which is the turbo flash mode on the 4 scanner that we have. So let me start these clips. From this difference in delay, you can understand that the new scanners with the high table speed don't really need triggering to see the aortic root and the proximal coronaries. Then a word about what to report from these acute aortic syndromes. Always report if the ascending aorta and the arch are involved. Pericardial effusion or hematoma and mediastinal or pleural hemorrhage is important because that makes it a much more urgent situation. Identify the tear if it is a true dissection and the falls and true lumen, because the falls and true lumen will provide blood to different organs. And the false lumen opacification. Is there complete opacification, partial or not at all? It could be thrombosed. Also important to report is involvement of side branches and organ enhancement. Distance of the entry side from the left subclavian artery is important, and I will show some classification why. And the aortic diameter at the level of dissection as well as proximal. And when you want to report on the aortic diameter, it is important to really be tangential to the long axis at that side of the aorta. So you have to try and be double oblique if the aorta is not going straight through the transverse plane. Then a word about the classification, and I want to stress that it is the radiological classification. And this can be found on Radiology Assistant, where parts of this presentation are also available. So classically in the radiological literature, we talk about Stanford A and Stanford B type aortic dissections, with the Stanford A including the ascending aorta and the Stanford B originating distal to the left subclavian artery takeoff. Classically, we thought that Stanford A would be surgical and Stanford B would be medical treatment. However, there are issues with this classification. We still use it in radiology a lot, and even in my center. But it's good to be aware that there are different interpretations in the radiological and surgical literature. The biggest point is that the involvement of the aortic arch is not really well classified. So if the arch is involved but not the ascending aorta, it is confusing to know how to call this in the type A and type B situation. So some authors have included a separate class in the recent years where the arch is involved but not the ascending aorta, and they call that a non-type A, non-type B dissection. If the ascending aorta is not involved, that is important, because a lot of these dissections that do not involve the ascending aorta are now treated non-operatively, where previously they were treated with stents or other operative means. A recent publication in Europe between the Society for Vascular Surgery and the Society of Thoracic Surgeons tried to address this by providing a new classification system for type B aortic dissection, so anything that originates distal to the left subclavian artery. And they included this, and it's something to maybe read and see if your institution would like to adopt this, because they will qualify if there is a retrograde extension of a type B dissection to the arch and beyond. I think for these classification issues, the most important thing is discuss with your local partners involved and make sure that you speak the same language and that you know from each other how you would like to, first of all, do the scan, and second of all, how you would like to report it. It is very important to always be speaking the same language. And for example, a mouse is not always the same to the people who try to understand you. So that was the technical component and how to report. Now I would like to go into the acute aortic syndrome as a clinical entity and describe the imaging features. So the acute aortic syndrome consists of three very similar pathologies: the typical aorta dissection, the intramural hematoma, and the penetrating atherosclerotic ulcer, as you can see here in the diagrams again from the radiology assistant with drawings from Robin Smithouse. So why are these three entities packed into one syndrome, the acute aortic syndrome? That is because they are very similar in their clinical presentation, the imaging approach, the classification, and often also the treatment. I like to think of these as triplets, very similar, not exactly the same, but very close. Let's look at the first one. Let's look at the clinical presentation of the syndrome. So it's the older patient, usually in their 60s or 70s, and mostly males, 2/3. All patients have long-standing hypertension, and they present in the ED with an acute aortic chest pain, which is severe and has a tearing and migratory feel to it. The location of the pain may relate to the origin. So a retrosternal pain more often has involvement of the ascending aorta, and the pain between the shoulder blades oftentimes is the descending thoracic aorta. Sometimes patients can present with syncope. They can present with a pulse deficit between the two arms, which is, if noted, usually only in the typical dissection. And there may be complications secondary to organ hypoperfusion, which is called the malperfusion syndrome, which could be either the brain or the abdominal organs, or at times also the heart if the coronaries are involved. A word about chest radiographs. This is the patient I presented at the first. It's good to know that in 25% of patients with a dissection, the chest radiograph is normal. In 75% of abnormal mediastinum on the chest radiograph, it does not always involve the aorta or dissection. It's still good to do the radiograph because it may show you a differential diagnosis to aortic dissection. It's very difficult, though, to not do a CT if the clinical counterparts in the emergency department are worried about aortic dissection or an acute aortic syndrome, better said. So let's look at the typical aortic dissection. This is always coming from a torn intima with an intimomedial flap, and here you can see a diagram with the entry site. Blood gets into the media and dissects the aortic wall, which gives a double lumen. On imaging, you will see the displayed intima calcification because of the displacement of the intima. You can see the entry site, not always, but mostly you can see it. And it's nice to see, and I will show an example where false lumen spirals around the true lumen, which it doesn't do in intramural hematoma. So let's look at some schematic representation of the true versus the false lumen. The true lumen is usually small and the false lumen big. The true lumen, of course, is continuous with the non-dissected aorta. Calcifications are circumferential around the true lumen, and the position is usually at the lesser curve of the aorta. The density in the arterial phase is higher than the false lumen, but the false lumen will have a beak sign and cobwebs, which I will illustrate. And usually, but definitely not always, the supply of the arteries, the branches, are different from the true lumen and the false lumen, with the false lumen almost always having the left renal artery. So here's a case of the true aortic dissection with a dissection flap. And here you can see the entry site very clearly. If we go down, you see that the true lumen has calcifications on both sides, whereas the false lumen only has the calcifications on the septum. There can be thrombus in the false lumen. And here's what I told already. You see the true lumen spiraling around the false lumen spiraling around the centrally located true lumen. So this is the false lumen, this is the true lumen. And if you go through it with a bit of speed, you see that it spirals around each other, and you don't see that in intramural hematoma. Again, the true lumen keeps having these calcifications bordering. So that's how you can keep those apart. In a still, and also because I couldn't show it, the cobweb in the false lumen and the beak sign, the sharp angle in the false lumen. This is the true lumen, the smaller lumen. The differential contrast enhancement of the false lumen and the true lumen being much brighter. And this is a type A dissection where you can see the entry point, and there is an extra point to make about a type A dissection, and that's the true lumen is always central to the false lumen, so the false lumen is outside. Complications in the typical dissection are rupture that can be predicted if the outer wall of the aorta is very irregular. Of course, if you see extravasation of contrast into the nearby structures, and a hyperdense pleural effusion, which is indicative of hemorrhage. A low density pleural effusion can be a reaction to the dissection. That does not always mean it's bleeding, but if it's an hyperdense pleural effusion, there usually has been a rupture of the aorta. Extension can occur either back to the aortic valve, which is retrograde, or antegrade to the abdominal aorta. And another complication is aneurysm formation. So in about 1/3 of the patients, these dissections will increase the diameter of the aorta, and especially of the false lumen. And if that occurs, it does tend to rupture in a later stage, and that may lead to late death. There are some further complications, and some are specific to type A aortic dissection. So intrapericardial rupture with cardiac tamponade happens in type A. Cerebral or coronary artery involvement, also in type A only. And aortic valve regurgitation, also only in type A. In both type A and type B, there are malperfusion syndromes because of blockage of the branching arteries, which is a strong predictor of poor outcome. And that blockage of the branching arteries can either be static or dynamic, or a combination thereof. And I'll show that by a nice illustration from this publication. So the static obstruction of the branches means that thrombus has formed, narrowing the lumen, which doesn't really change during the course of the cardiac cycle. The dynamic obstruction is a flap from the true lumen that, with pressure differences in the cardiac cycle, moves a little bit. So the lumen of the true lumen can actually be a bit bigger in diastole, or in systole, and then collapse in diastole. And then there's the mixed one with thrombus in the false lumen and the dynamic flap of the true lumen. If the true lumen has this curvilinear shape, this is actually more indicative of ischemia of the side branches. If it has this lentiform configuration, it's usually more benign, because the true lumen can still have a higher pressure than the pressure in the false lumen. When the false lumen gets a very high pressure, it starts to exceed the pressure in the true lumen, especially in diastole. So again, report in the report where the intimomedial flap is, the involvement of the branch, the aortic arch branch arteries, and that can go quite high up. This is the common carotid artery with the dissection, and that's how you get issues with the brain perfusion. But also lower down, the mesenteric artery branches, and here you see it in a sagittal view. This is a specific situation with the type A dissection, and you can see that this is the dynamic flap, and the true lumen is really small, and it also involves the origin of the left main artery coronary branch. So that is important to note in your report too. Now we move to intramural hematoma, which is about 10 to 20% of the acute aortic syndrome. And while we are dealing in general with older patients, patients with intramural hematoma are usually a bit older than the ones with the classic typical dissection. Sometimes this is an incidental finding. People think this is because of the rupture of the small vascular branches that go into the aortic wall to supply the aortic wall of oxygen. But there is some debate. It could be also from an intimal tear that has sealed off and you don't see the entry anymore. The unenhanced CT is very important. You will see a smooth crescentic or circumferential hyperdense collection in the aortic wall. No luminal narrowing usually. And again, the intramural hematoma does not spiral, or usually doesn't spiral. Internal displacement of intimal calcifications is similar to the aortic dissection. And most frequently, this occurs in the ascending or the proximal descending thoracic aorta. After you give contrast on the CTA, you do not see enhancement of the intramural hematoma. However, be careful if you don't have an unenhanced CT. If it is a shallow or minimal intramural hematoma, you may just think it's normal, or not normal, but it may be thickening of the aortic wall due to plaque. If branches are involved, they are usually not occluded, but the lumen is narrowed. So here are some examples. Again, this is the unenhanced CT with the hyperdense intramural hematoma. And you can see that it's somewhat difficult to pick up in the more distal descending aorta, but still the same occurs. The true lumen is bordered by the intimal calcifications. After contrast, in this case, it's fairly easy to see still. The density has not changed. It just looks a bit less dense because of the density of the contrast next to it. The intramural hematoma going down. So complications of intramural hematoma are progression to a true dissection in up to about 50% of the patients. Rupture occurs in 20 to 45% of the patients. And ulceration of the intramural hematoma by secular aneurysms does occur. A late complication could be a fusiform aneurysm as well. Predictors of complications are the fact that if it is a type A intramural hematoma, so if it involves the ascending aorta, if the diameter at the level of the dissection is more than 5 centimeters, if the thickness of the intramural hematoma is more than 2 centimeters, or if it's increasing in subsequent CTs, and of course, if you have pericardial or pleural fluid, and especially hematoma. However, if the aortic diameter remains normal, this condition usually resolves in up to 80%. Another word to say about detecting this on the unenhanced CT is that you really have to narrow your window. You will see the displaced calcifications in the regular soft tissue window, but if you narrow the window down, you can see that hyperdensity is much more appreciated. And then this is a case just to show the diameters. If this diameter at the level of the intramural hematoma exceeds 5 centimeters, or if the intramural hematoma exceeds 2 centimeters, you are at increased risk of progression and complications. Something I learned a few years ago after this publication is that there is this distinction to be made between the intramural blood pool and the ulcer-like projection. So the intramural blood pool, as you can see in this publication, has a very narrow connection to the true lumen. And usually has a side branch coming off it. An ulcer-like projection has a very broad base and not really an opposite branching artery. And the distinction is important because the intramural blood pool is not associated with poor prognosis, but the ulcer-like projection is. This progresses and this usually resolves. So let me show you in a case from my own experience. This is an intramural hematoma at the time of presentation. After 8 days on a follow-up CT, you can see a tiny little bit of contrast in the intramural hematoma in the proximal descending aorta, and this much more irregular looking aorta in the descending aorta. In a scan about 2 weeks later, this has remained similar in size, while the the projection is increasing, and even further down the line at 6 weeks, this still remains the same, and you see the intramural hematoma is resolving, whereas the ulcer-like projection is increasing in size. That is different from the last entity, which is the penetrating atherosclerotic ulcer, which is ulceration of an atheromatous plaque, and it penetrates the intima with focal hematoma in the media. It usually occurs more distally than the typical dissection or the intramural hematoma. This only happens in patients with severe atherosclerotic plaques. And here you can see the non-calcified aortic plaque in a schematic. And here there is an ulceration, but the ulceration doesn't penetrate the intima. And this is what is really called the penetrating atherosclerotic ulcer, where the intima has been penetrated and there is hematoma in the media. I would really like to advise to only call an acute penetrating atherosclerotic ulcer in this condition, which will give pain, because if it's this condition and there is no pain, it usually is an incidental finding. So again, this happens with advanced atherosclerotic disease, as you can see in this patient that has multiple secular aneurysms for prior penetrating atherosclerotic ulcers. There are focally displaced intima calcification. Usually the ulcer is focal and often multiple, as in this patient, and there is only minimal focal media hematoma. The wall of the aorta in these patients is so fibrotic and that the intramural hematoma does not have the ability to extend due to the scarring of the wall of the aorta. Sometimes in these patients, the wall of the aorta does enhance. The prognosis in these patients is poor if the diameter of the ulcer is more than 20 millimeter and the depth more than 10 millimeter. There is a higher risk of progression. You can see these secular aneurysms as an incidental finding later in stage, but these can actually progress to rupture. However, sometimes you see them as a large secular aneurysm just as an incidental finding. So now we have gone through the three entities. Let's talk a little bit about management. As I said before, this has evolved in the last decades. It's way less aggressive at the moment with way more stenting or medical treatment than open surgery. Open surgery is usually only done in the type A dissections, and some people really do the type A dissections if there's clinical need. In the acute stage, when they are still in the emergency department, they all get blood pressure control to prevent progression of the disease. So this is something to really convey urgently to your clinical colleagues, is if there is blood in the pleural space, if there is blood in the mediastinum, if there is blood, even if it's small amounts in the pericardium, or especially, of course, if there's larger amounts of blood in the pericardium. One other thing to keep in mind is that the pulmonary artery wall and the aortic wall are in very close proximity to each other, and you can have extension of the dissection or the intramural hematoma better into the pulmonary trunk wall. And I only saw a case in literature for years, but we have now had a few cases where we see it in real life. As you can see here, there's narrowing of the pulmonary artery by extension of the intramural hematoma into the pulmonary artery wall. And patients can, because the wall is so much less strong in the pulmonary trunk, there may be an occlusion of the pulmonary artery much quicker than other complications in the aorta. A long-term complication, as I've already illustrated, as in this patient as well, is aneurysm formation of the aorta. And in this patient, there were two regions in the ascending, in the proximal descending aorta, and in the abdominal aorta. You can see that the rupture of the false lumen has occurred. So let's show some cases to bring some of these points home a bit more. This is a chest radiograph, and you know that we're looking for the aorta, but I don't think it will be easy to see the dissection. This is the CT of that patient, and I'll go through it. You can see contrast given to the left, which really hampers evaluating the branches of the aorta very nicely. What you also see is there's really very poor enhancement of the aorta with a sort of a swirling density to it. And there's high density still in the pulmonary artery. There's a large amount of hemopericardium with the contour abnormality of the right atrium, which indicates that there is tamponade because the pressure in the pericardial space is higher than the pressure in the right ventricle. And then there's layering of contrast in the IVC, and the contrast goes really deep into the hepatic veins. And here you can see that same as well, and the contrast really goes very inferior. So this is not normal reflux of contrast. This is really a specific condition. And if you see these things on the CT, you have to call your clinical colleagues that this patient is about to die. This is what I call the features of a pre-mortem CT. Again, here they are, the heterogeneity of the contrast in the aorta, the very dense contrast in the pulmonary artery and in the right side of the heart, and the extensive reflux of contrast with layering in the IVC because of the lack of the pressure in the IVC. These are all signs that the cardiac output is so poor that this patient is in a pre-coding situation. This is another chest radiograph of a patient coming into the ED with acute chest pain. And I think, again, you didn't really observe a dissection there. This is a patient with extensive intramural hematoma. And if we go back again, the artifacts from the contrast in the left arm are preventing proper assessment of the branches. You can see that there's not really spiraling of the contrast, of the intramural hematoma, and the lumen is not all that narrow, but it does go all the way back to the aortic valve, the aortic root. This is not the right coronary artery, but actually contrast leaking into the intramural hematoma. And I'm showing this case in part to show that even if you trigger with our old scanners, this was a case from before our new scanners, it isn't always optimal because you get these step artifacts and it becomes quite tricky to see where that entry site is. Luckily, we caught it on the axials here, but you have step artifacts of the triggering. This is a case, and I'm not showing the radiograph, but a case that to this day we still don't know. There was acute chest pain and this very weird looking aneurysm in the aorta, and we think it may be from a dissection. But there was a second site, and we were very much debating whether this is from an acute aortic syndrome or maybe an infection, so a mycotic aneurysm, or Behçet syndrome that can give very weird aortic aneurysm. Here is a curved multiplanar reformat and a 3D volume rendering. And this is in part to also illustrate that sometimes it is not very easy to provide measurements. So these you can encounter. This patient was treated with a stent, and I'm also showing this patient because after the stent, at some point there were again symptoms. And while the aneurysm was well treated and this looks much more normal, I wanted to show that the arterial phase and the 90-second delay phase have a very different meaning for pickup. And here you see the sagittal ones for pickup of the endo leak after stent placement. So if there was a stent, you have to do a delayed phase if there is a possible concern for endo leak. Going to yet another chest radiograph. Again, I would challenge anyone to pick up an abnormal aorta in this case. This is the CT. And if I go through it, you will see a classic dissection. You see how nicely you can judge the branches of the aorta because the contrast was given to the right arm. You see the entry site. And one of the complications, the aneurysm formation of the false lumen. So this is a type A dissection. In this case, this is after that patient that I showed before got surgery. and we're going down to the level because this patient was not doing well in the intensive care. And we got a bit worried because you can see there's still fluid around the new surgical ascending aorta. And we saw this hyperdensity in that region. So we were thinking, is this contrast extravasation? And this is just to show how much you sometimes need, and especially in a post-surgical setting, the unenhanced CT. Because when they do these repairs of the ascending aorta, they usually use felt to repair the aorta. And you really need this unenhanced CT to know that this is surgical felt, so surgical material, which has very similar density to the contrast after the contrast administration. So there is really value to doing these unenhanced CTs, especially if there had been treatment, but also to pick up the subtle aortic intramural hematomas at times. This is a still of the same. One more case of a radiograph. And here is the accompanying CT. And I think you can already observe the hyperdense intramural hematoma, and you can see it can be very shallow. And sometimes you may not pick up from a post-contrast CT. So again, the unenhanced CT is important. I think this is my my final case, and then I'll show the first case that the first radiograph that I showed. This is a post-contrast CT, as you can see, from a patient with a dissection flap that you can already appreciate on the branches. And if you look better, it's actually all the way in the common carotid. It involves all the branching arch vessels. You can see this very narrow collapsed true lumen. And if we go to the ascending aorta or the aortic root, you can see there's already aneurysm taking place. And true lumen is not only involving the coronary artery branches, but you can see prolapse through the aortic valve into the left ventricle, which is extremely rare. And then you can see how narrow this true lumen is. And the involvement of the aortic branches, you see the differential enhancement of the kidneys. So there is organ malperfusion in the right kidney. Another component of organ malperfusion that you can see on the arterial already, but is much more readily appreciated on the partly included heart in the abdominal phase, is this endocardial hypoenhancement, and also the papillary muscles are not enhancing. And you can see it here more subtly in the arterial phase, much more readily in the portal venous phase, where again you can also see more readily the malperfusion of the other organs. So I would advocate to always have the portal venous phase included. And this was a trauma case, and actually 3 out of the 4 cases before this were also trauma. So while I specifically lectured on a non-traumatic topic, of course, if the patient is in very acute, very severe chest pain, and if they are in a car, or even if they collapse on a bike, they can be brought in as a trauma case, and you could be non-expecting the aortic syndrome. I apologize, this is just the same patient, and I'm showing the prolapse of the true lumen into the aortic valve. here in a coronal view. So finally, going back to that first chest radiograph, this again, I don't think you would have picked up, but is a type A dissection of the aorta with some of these imaging findings that I've illustrated throughout my talk. Now, there are many other things that can happen with the aorta that I have not touched upon that is possibly good to be aware of. So infection, mycotic infections, and I'm also including this CT to show how daring some of our interventional radiology colleagues can be draining these collections next to the pulsating ascending aorta. And then infection or inflammation in around the aorta as well. These I have not spoken about, but of course also can occur on your imaging. So what I would like you to take to work, and sorry that I ran over time, the acute aortic syndrome is a life-threatening syndrome existing in patients with hypertension and atherosclerotic conditions. Don't trust your chest radiograph. Give contrast through the right arm if possible. Optimize your CT protocols and use the unenhanced CT or a virtual non-enhanced CT if you have dual energy CT. Do CT at 60 seconds for malperfusion and at 90 seconds delay by indication for endo stents. And most importantly, talk to your surgeons for desired classification and technique, as well as arch involvement. And when you do measurements to provide care for them, be perpendicular to the vascular axis. And with that, I come to the end of my talk, and I would really like to thank you again for the opportunity. And please have any questions if you have them now or later by email. I can show that again. My email is on all slides and also at the beginning. I'm happy to answer any questions.
Professor Burgess, thank you very much for a great lecture. And I guess we have a little time left for the Q&A session. And I would like to remind everyone in the audience that you have an opportunity to print out a question in the chat room of this conference. And of course, if you would like to ask some personally, please just speak up and let's hear the questions from the audience. Thank you.
Dear Professor Berger, thank you for your lectures. My name is Andrei Mango. I'm from Kharkiv, Ukraine. Thank you for your support and for support of Canada. So the question is, how often you see in your practice dissection without forming two lumen? So the dissection just rupture of intima, the Svensson type 3 classification.
Yeah, so usually in the classical aortic dissection, as I call them, with an intimomedial flap and an entry site, there is some entry of contrast. However, sometimes the contrast needs more time to get into the false lumen, especially if the pressure in the false lumen is not very high at that moment in time. So when you think you are dealing with a classical dissection with a true intimomedial flap with an entry point, there can be two things that make it very hard to distinguish it from an intramural hematoma. One is contrast is not yet entered into the false lumen, or the false lumen is not partly but completely thrombosed. Completely thrombosed false lumen in the classical dissection does not happen often, but it can happen, and it becomes very hard to distinguish it from intramural hematoma. The best way to distinguish the two would be to look at the spiraling of the false lumen around the true lumen. I think that's the best way to see if something is a thrombosed lumen or a intramural hematoma. To be honest, it does not really matter for the treatment. At least in many centers, even if the arch is involved, both would be treated non-operatively, at least at the first instance. If the ascending aorta is involved, they are much more aggressive, even in intramural hematoma. So it's not that important to distinguish a thrombosed false lumen from an intramural hematoma. The other thing I should point out for the distinction between the two is that the intramural hematoma in the side branches is usually more symmetric and homogeneous and doesn't really narrow the lumen very much, whereas the classical dissection can severely narrow, for example, the common carotid lumen or the brachiocephalic trunk lumen. So if there is not a lot of narrowing, if it's a very shallow and concentric appearance, it is more likely intramural hematoma. I hope that answered your question a bit.
So thank you very much, but I also ask about the situation when not intramural hematoma. We don't see intramural hematoma and we don't see two lumens, but we see the small intimal flap and just bulging of aortic wall. So just formation, this bulging outside the aorta. This is Svensson classification type 3. So are you seeing such situation in your practice?
No, well, we don't see that very often, and if we see it more often as a incidental finding, actually. So then there's, you mean when there's a short segment dissection with aneurysm of the false lumen and a clear entry site. Is that, do I understand that correctly?
Not yet, but I have, if I can, I have next question. In Ukraine, we didn't have a lot of CT with fast pitch. So with two tube and fast pitch. So if we have just 64 slices or 128 slices CT or even 16 slices CT, use routinely ECG gating for such a acute aortic syndrome?
So we actually, till about 1 year ago, had 3 scanners. So we have 4 CT scanners. Till about a year and a half ago, 3 of those were 64 slice scanners, 14 years old, and 1 CT was a 16 slice scanner, also 14 years old. We did not routinely gate for patients in the ED because they ask it often, but it is not present often. So we would do the best we could as for speed, as high a pitch as we could, but do the aorta without triggering. We would report those and be at the CT console as a radiologist to give an urgent impression of whether there was dissection or not, and if there was dissection, whether we thought we needed a gated CT, which we in that case would mostly do as a second problem solver. When you get really used to these dissections, most of the times you are pretty sure it's pulsation artifact. So we would reserve it as a problem solving tool. However, in patients that have a dissection and come back after 2 days, if there was still some hesitation, we would do the follow-up CT with triggering in a less urgent setting. But the patients coming from the emergency department, we would almost never trigger.
Okay, thank you very much. And maybe the last question, if it's possible, how you calculated volume of contrast for such exam?
We now give IV contrast based on weight. We have a new injector together with the new CTs. Previously, we had a standard dose of 120 milliliters of contrast, and the contrast was 320 milligrams per milliliter of contrast. And so we had a same dose for everyone, 120 milliliters. Now we are basing it on weight of the patient, and that's an automated formula in the new injectors that we have.
Okay, thank you very much, Professor Bell.
No, we're glad, happy.
Professor Berger, thank you very much. There's questions from the audience in the chat, and it's regarding the pulsation artifacts. So our colleague asks whether you have in your practice cases where the pulsation artifacts were impossible to distinguish from aortic dissection, and do you repeat the examination if you consider the first CT acquisition to be inconsistent? Thank you.
Yes, thank you. Yes, we do have cases where we are not sure. And again, like anything else in radiology, there's variation between radiologists. So some are more sure and others are less sure. And given the fact that this usually happens in patients of an older age, the radiation, of course, is important, but if needed, if there is uncertainty about pulsation versus flap, we will have a low threshold for doing a second CT with triggering. But we try to really reserve that for patients where there is uncertainty. And in most patients, we are quite confident without the triggering. And especially now with the new Siemens Force, the table speed is so high that we don't have pulsation artifacts anymore. And that's not only Siemens, so I'm not trying to promote Siemens. In GE, Canon, as well as Philips, the machines now can also scan with much higher table speeds, either because they have much wider detectors, or they find other solutions. So even in the other companies, they can scan and visualize the aortic root much more reliably, even without triggering. But of course, I understand that those scanners are fairly new. And even at Sunnybrook, where I worked, we, as I have said a couple of times now, we were dealing with 14-year-old scanners till about a year ago. So it really depends a lot on the local situation. But if you do have these advanced newer scanners, you definitely mostly don't need triggering. If you have the older scanners, I would reserve it for the patients where you are uncertain to say it's pulsation or it's a true flap, and have a low threshold. Again, these patients are usually 60, 70 or older, and doing one extra CT is of course not as problematic as doing it in a 20-year-old. And I've also had cases where in a trauma patient, we were not sure about involvement of the aortic root in a younger patient of 30 years. And it's a very important finding, of course. So there have been a few cases where we did a second scan with triggering, even in the younger patient, if it's needed.
Thank you very much, Professor Berger. And we also have another question from the audience regarding the MRI. And it's about whether you think there is a place where there's a diagnostic value of MR imaging in the setting of acute aortic syndrome. Thank you.
Yes, in Canada, we have very limited access to MRI, at least at the center where I work, and a lot of the time that is available gets dedicated to cancer care and neurologic imaging. I come from the Netherlands in Amsterdam, where MR was more available. Still, my talk is only dealing with CT because I mostly talk about the acute imaging in the patient that comes from the ED. In that setting, I think CT is the first choice because of the patients not being confined in the scanner for a long time. If you have an MR with very fast protocols, you could do MR, but be mindful that a lot of the monitoring of the patient coming from the ED may not be suitable for your MR room. So in my experience, MR is very valuable, but mostly for the follow-up imaging. So once the decision has been made to admit the patient to the hospital, or and there are follow-up imaging studies needed, then almost always you could do MRI, except for the situation in Canada where we still would do CT oftentimes. But in my Dutch situation, we would almost always do MRI in the patient that is not from the emergency department. And of course, if it's a ward patient that has a very urgent new indication, then we would do CT as well. MR is just more complicated in the patient that is really emergently supervised for something very acute.
Thank you very much, Professor Berger. And if I may, just another one, maybe one question. You've mentioned with the last cases you presented those were the trauma patients, and I would like to personally ask you, would you suggest some findings that would be prognostic of a poor outcome in a scenario of a younger trauma patient, but not an older atherosclerotic patient? Because unfortunately, we nowadays need to deal with a certain amount of combat radiology and combat trauma, and of course, there's a scenario of large vessel dissection in those younger patients. So, what are the signs of a poor prognosis in these scenarios, not in an elderly atherosclerotic patient? Thank you very much.
Yeah, that's a very good question. I think most of the poor prognosticators still remain the same. But the most important one is side branch involvement with organ malperfusion. So if you have a traumatic, I have a different lecture that I'm happy to give some other time about traumatic aortic injury. In the cases I showed, the acute aortic syndrome was the cause of the trauma. It was not caused by the trauma. So if it is in combat radiology, a younger patient with trauma as the etiology of the aortic injury, the most important ones are the contour irregularity of the outer wall of the aorta, and especially if it's more than 180 degrees of involvement of the outer layer of the aorta, that is that really gets aggressively treated. In a pseudoaneurysm that usually forms, it depends on the circumference and the length of the pseudoaneurysm. The other thing is, and I have seen about 20 cases in my career where there was extravasation visible. That is, of course, a very poor prognosticator, but because we treat a lot of these patients with endovascular stents nowadays, actually a fair amount of these patients with active contrast extravasation on the CT, as long as you are there and can make that diagnosis immediately, will survive with endovascular treatment. But if the injury extends more inferiorly to the arch branches to involve the arch branches or the abdominal branches, then the malperfusion of the end organ is a very poor prognosticator. So there are a few things to look for. If the outer contour of the aorta is normal and the injury is only inside the aorta, so either minimal aortic injury with a small clot or a small flap, or then we usually just monitor these patients by scanning them again after 2 days and after 1 week or 10 days to see if the injury heals, because usually in the younger patient, that is the case. So very important, it's to judge the outer contour of the aorta and the size of a possible pseudoaneurysm, and of course, extravasation.
Thank you very much for your answer. Thank you. So let me just please once more double check with the chat and all the inquiries from the audience whether we have any questions left. To my knowledge, now we do not have any new questions coming in. So once again, Professor Berger, thank you very much for the lecture, for this great material of extremely high educational value for our audience, I guess. And I would like to remind our audience that this webinar will be available as a recording after the editing for the active members for RU at the site of RU. Thank you very much.
I would also like to thank you very much for giving me the opportunity, and sorry for running over a bit, but thanks a lot for the opportunity to provide the lecture.
The pleasure is all ours. Thank you. Professor Linsky, would you like to have
Yes, I would
some
like to
closing
add
moment
only.
here? Thank you.
Yeah, I would like to add only that thank you, Professor Berger, for your interesting lecture, and a lot of question indicates a big interest for this topic, of course, and we will continue our seminar next month in February, and it will be announced probably on the next week, I think. Thank you very much again. And I'm sure that probably in the later it will be possible for us to meet offline in Ukraine or Canada or the other country. Thank you very much again.
Thanks.
Микола, тут є чи ні? Алло.
Excuse me?
Ви є тут? Ви ще є?
Так, безумовно, ми завершуємо. Thank you once again for everyone from the audience. We'll meet again the next webinar. Thank you for your participation, and once again, thank you for our lectures. Okay, I guess we might finish our conference now. Наталя,
Дякую.
Дякую.
Дякуємо всім за увагу. Дякуємо, до побачення.